Anterior hip pain presents a significant clinical challenge. Accurate, clinical objective testing for labral injuries remains a significant source of debate as current practice for identifying labral pathology is inadequate. Please take a moment to look over the aims and objectives. The prevalence and incidence of labral tears are unclear because some studies suggest that labral abnormalities are a natural part of aging, whereas other studies associate labral tears with joint pathology and pain. Martin et al. Believe 90% plus of patients with anterior hip pain will have labral tears, while McCarthy report that labral tears are the most common cause of mechanical hip pain. The acetabular labrum has been compared to the labrum of the shoulder. Although not as complex functionally, it is still very important to the health of the joint. The stability of the hip joint is enhanced by the presence of the labrum. This provides a fibrocartilaginous extension of the bony acetabulum, increasing the depth of congruency for the femoral head. Furthermore, the labrum provides a seal, maintaining a negative pressure which generates a suction effect. This also serves to distribute compressive loads, thus reducing cartilage stresses during functional activities. It's an innervated structure, serving to provide proprioception, but this also means that it can be a source of pain. It's feasible, therefore, that labral lesions can significantly impact on the ability of the hip to perform its desired role. A multitude of overlapping clinical entities is associated with anterior hip pain, which highlights the difficulty in making an accurate diagnosis, and as a result, etiology is often difficult to determine. For the purpose of this presentation, I will subclassify tears into degenerative tears, dysplasia, FAI, and traumatic tears. Degenerative tears may involve one or more regions of the labrum and can be seen in inflammatory arthritis and can lead to degenerative changes. However, they may just also be a part of the normal aging process. Dysplasia. There have been many studies linking the presence of dysplasia to tears of the labrum. Dysplasia such as leg-calves perf disease and congenital hip dysplasia are now well known to cause labral tearing, as they expose the labrum to abnormal biomechanical stresses. FAI. Femoral acetabular impingement occurs when a structural or spatial abnormality of the proximal femur or acetabulum triggers damage to the labrum, usually during high flexion and internal rotation movements. But according to Gantz, FAI is the most predominant cause of labral tears in the non-dysplastic hip. Traumatic causes. Traumatic injury to the labrum can result from a number of causes as seen in the slide below. Isolated labral damage is rarely seen but can occur due to dislocation or subluxation, according to Groen Herrera in 2009. Several researchers have suggested that the labrum is a weight-bearing structure in the extreme of hip range of motion, and it is in these extreme positions of range where the labral might actually be torn. Clinical presentation will differ depending on the etiology of the tear. The following clinical signs and symptoms should increase suspicion of labral pathology. However, I feel salient to point out that symptoms, signs, and clinical examination in detecting labral tears is of limited use, and that the most important part of diagnosing hip pain is the subjective. Patients will usually present with a long duration of symptoms, unless they can recall a traumatic event, most commonly when the leg is hyperextended and externally rotated. Alternatively, patients may describe pain when participating in sports involving cutting, twisting, and pivoting movements, which can cause microtrauma to the labrum. In over 90% of cases, the patient will complain of anterior hip and or groin pain, which is associated with an anterior labral tear. Less frequently, the patient may report pain laterally or posteriorly, which can be indicative of a posterior labral tear. Patients may also usually complain of localized mechanical symptoms, such as painful intra-articular clicking, locking, catching, giving way, or guarding of the hip. Of these symptoms, in my experience, clinical painful clicking appears to be the most consistent finding. However, it is not always necessarily present. Therefore, caution should be used to avoid over-interpreting painful clicking as necessarily an indication of labral damage, as there can be other causes for this type of clicking. The gold standard diagnostic test for detecting a labral pathology is an arthroscopy, while a fluoroscopically guided intra-articular injection is very useful for differentiating between intra and extra-articular sources of pain. Gadolinium-enhanced MRA is thought to be the diagnostic imaging of choice due to its high sensitivity and specificity values. There is very limited evidence to support the use of physical examination to detect intra-articular hip pathologies, with particular reference to labral tears. Due to the brevity of this presentation, I have only included some of the tests I would normally carry out to detect a labral tear. Get the patient to walk 3 to 4 stride lengths and view from the front and behind, and look for any abnormal gait. Then I would get the patient to stand on one leg to detect deficits in proprioception of the extremity and function of the abductors to hold the pelvis in a balanced position. A positive test is a pelvic shift or decrease of more than 2 centimeters. Assessment. Then I would test active range of movement with overpressure to rule out the lumbar spine as a source of pain. From anecdotal experience, I would expect to find some pain on lateral flexion and on quadrant testing to the involved side due to loading of the involved hip. To rule out a lumbar disc as a source of pain, I would carry out a slump test and passive straight leg raise as seen on the video. If all testing is negative so far, I can be reasonably confident in ruling out pathology from lumbar spine as the main source for anterior hip pain. However, due to the regional interdependence theory, I would not rule out the lumbar spine as a possible contributing factor to their pain. Move on to test the hip, beginning with active range of movement, strength and muscle length tests. Physical examination may reveal reduced range of motion, especially for rotational movements, and a deficit in muscle strength and length. Moving on from this, I would carry out the following orthopedic tests to help detect the labral tear: Fabers and log roll. The purpose of Fabers is to test for pain and range of movement through placing the hip into flexion, abduction and external rotation. According to McGee, a positive test is considered when anterior pain is reproduced and when the tested leg remains above the height of the other leg. There are still a lot of debates around the accuracy of this test. The literature contains many alternative methods for its application, as well as interpretation of the findings, thus impacting on its inter-rater reliability. In clinical use, it's particularly non-specific, as it is unable to differentiate between dysfunction at the hip joint, SIJ, lumbar spine, and surrounding soft tissues. The log roll test is used to assess for acetabular labral pathology and general laxity of the hip joint. The log roll requires the clinician to place the patient in supine with both legs in neutral for hip flexion, extension, and abduction. The clinician then maximally internally and externally rotates the femur and compares movement with the other leg. A clicking sensation may indicate an intra-articular pathology. Such sensations, coupled with pain during this test, is a comprehensive finding as it reveals the provocative nature of isolated hip internal rotation even when the hip is placed in a neutral position. The complexity of the anatomy and biomechanics of this region ensures that the labrum remains an under-recognized source of anterior hip pain, highlighted by an average of 2 years in duration of symptoms before diagnosis. Early recognition is essential and may reduce the chronic degenerative course of this condition. The clinical presentation, subjective and physical examination will yield useful information. However, due to the level of evidence for orthopedic tests detecting labral tears is poor, therefore current practice still relies on arthroscopy as the gold standard. The importance of subjective assessment cannot be underestimated and will provide the foundation for the objective assessment. Individual use of tests cannot be advocated given their poor specificity. However, an assessment algorithm utilizing a battery of tests has yet to be developed and may be helpful. Therefore, future research could aim to develop the accuracy of the tests regarding this clinically significant and challenging area and possibly develop an assessment algorithm.